Awesome. So thank you all for coming today. We know that the summer is very busy and a lot of people weren't able to join, but we really want to make sure that we prioritize having this conversation about harm reducing language. We know that in February, we had a conversation about the environmental scan, and one of the 6 sections that we reviewed was about the narrative and the language that we were using. And there was a lot of feedback on what does that entail? Can we learn more? And so this presentation today is really geared towards the first step, at least, of tackling that conversation. So let's change slide. So today, not only will we try to dive in and understand what harm reducing language is, we'll also identify issues with conventional public health language, terms that we typically see. So again, in the environmental scan, some of the words that we came across that we flagged were vulnerable populations or at risk or high risk. And so we'll kind of dive into what those conventional terms are, and also finding out ways how we can utilize different terms that are more accurate, that are more sensitive, and actually get to the root of the cause. And so we hope by the second half of the call, we'll have time to kind of actually take on some of the principles and the conversations that we had today, and the resources that we provided, and have some practice time in reframing some text. So really looking forward to diving into some breakout groups and going into that practice with you all today. So I would love to open up the floor on what you all initially thought of when in the environmental scans and you looked it over and you saw a victim blaming language or harm reducing language. Because I think one thing that is hard for us to discuss when we're talking about harm reducing language is that there are so many different terms in relation to this. And so one of the resources that we provided in your Google folder drives or your state folders were resources, and some of the titles varied. So you didn't necessarily see harm reducing language, you saw inclusive language. So curious to see what you all's perceptions were of that, and you're free to add that into the chat. But I think we'll just dive right in and take the time to kind of describe what our perceptions are from AmChip's side of why harm reducing language is so important. And so I think at its core, there are 2 main things that we're trying to do when we're using a different approach or harm reducing language. And that is really to avoid language that stigmatizes individuals for their conditions that they experience as a result of systemic imbalances of power. And I think one of the easiest or most common examples is when we say that Black women Black women are 3 to 4 times more likely to die of childbirth than other racial groups or their white counterparts. And part of that is the language does not attribute to what's the root cause. It makes it seem like it's inherent to being Black that you're going to have this type of poor health outcome. And we know that to not be true, but the simplification in the language that we typically use is problematic. And so harm reducing language really is driven to try to avoid that type of stigmatization, but also, again, at its root is to be accountable. And so we're hoping that by using harm reducing language, we redirect the blame from persons affected to acknowledging the perpetual harms caused by systems and structures that hold that power and privilege. So is it really that because I'm a Black woman that I'm going to have these adverse health experiences, or is it that we're not listening to women in clinical care, or we're not listening to birth support people who have leadership in these roles? Are we discrediting them? And so making sure that in our narratives, when we're writing our executive summaries in our Title V grant applications, and annual reports, are we being accountable? Are we really acknowledging what the root cause is when we're writing these statistics? So as we mentioned before, this conversation is really driven by some of the feedback that we received when we presented some of the high level information about the environmental scan that we did in 2021. And one of the most common frequently used terms was high or high risk or at risk. And so we'll kind of take a dive into some internal and external guidance. One thing that I want to emphasize here is that we tried to provide as many resources that we could that was in depth and comprehensive, but there isn't a standardized tool as of yet. Neither from AmChip or any other national organization on any set rules. And so what we're providing today is really an internal guidance, if you will, on how you can kind of reframe the language. So keep this in mind. The term high and at risk isn't inherently bad, but it's when we're not being clear, we're not attributing what the root causes is truly the issue. And so before we get into some of the guidance, I wanted to show some pretty normal examples of conventional public health terms. And so I'm sure we've all seen terms like risky behaviors as a descriptor of certain populations, vulnerable populations, risk factors, social problems, and intervention. I feel like I've been talking a lot here, so I'm gonna pause and encourage anyone to either get off of mute or chat in the comments on what are some other terms that we could use instead of some of the ones that we're so used to seeing, like such as those that are on the screen. All right, well, it's a little silent, but that's okay. I know this is an important conversation, but it is a conversation that we're not used to having. And so we'll just plow through and kind of see what are some other disadvantaged. Yes, thanks, Cheryl. Priority populations instead of vulnerable populations. I like that. Another term that I did not include here, but you're probably pretty used to is target populations. And I think one of the things that we think of or that we should consider as we're moving forward and reframing our language is making sure that it's not based in disparity or based in violence. So those are some things that we want to consider, but I'll move forward and kind of provide some other terms that could be used in instead of some of the conventional terms that we see here. So if we're thinking about terms in more of a health equity lens, rather than discussing risky behaviors of a certain group of people or population, we might want to discuss what are the dangerous conditions that they're living in that perpetuate a poor health outcome. And instead of vulnerable populations, what are they actually vulnerable to? Are they vulnerable because they're vulnerable, or are these populations oppressed and under threat by systemic issues that are not being addressed or purposefully being perpetuated for certain populations to live in food deserts and areas with poor health or poor water or sanitary conditions? So these are some things that we always want to consider, that the current conventional language that we use is very vague and it doesn't actually attribute to what the issues are and perpetuates this notion that it's victim blaming essentially. So another term that we saw on the other page was a social problem. And what is the social problem? Is it actually racism or social injustice? Or, again, what harm reducing language and reframing our narratives really wants us to be more specific and really attributing to what that root cause is. And then intervention, I think that one was an interesting term that I found, because again, none of these terms that we saw on the other slide is necessarily wrong, but the problem is that it doesn't attribute to what, it does not indicate what needs to happen or what is currently happening. And so do we want to make interventions? And so as the outside group coming in, or are we trying to create social change, working with the populations to make better health outcomes? And so these are some things that we want to consider. I see some movement in the chat, so I'll just take a pause to read. Interesting, that was going to be my question. Okay. And so we hope that you all had the opportunity to review some of the materials that we dropped into your state folders, whether it's the Google Drive or Dropbox. There was a pretty great document from the Oregon Health Science University Inclusive Language Guide that I would really encourage everyone to take a look at. We won't have the time to dive deep into them, but one of the things that we wanted to kind of cover is some of the principles on how they came up with the guidance. And so this is not all encompassing either. There's additional principles that's listed in, excuse me, listed in the document. But I just wanted to highlight a few of these and note that one, identity is personal. And so often when we're writing narratives, especially when we're talking about specific stats and things like that, we are not attributing, we're forgetting sometimes that these are individual people with stories. And so while we are trying to understand everything that's going on in a certain population, making sure that we're describing individuals in a way that's respectful and honest and reflective of how they see themselves is very important as we're moving forward and trying to understand how we're reframing language. Again, being respectful and being specific, saying exactly what we mean. So again, many of the terms, conventional terms that we've seen, that we've highlighted already are not inherently bad, but they aren't reflective of what's actually happening. What are the root causes? And so these are the types of things that we want to make sure that we consider. And ultimately being thoughtful and intentional in the language. So I know this is very high level in the principle, but I believe on page 4 of the Inclusive Language Guide, they go into detail of the different principles. The entire document is amazing. And so I'd love to encourage you all again to take a deeper look into that as an external guidance. But I'm also really excited to pass the baton over to my colleague Salome, who was really instrumental in developing some internal guidance from AmChip for the Innovation Hub glossary of terms that we have. So without further ado, I will pass it on to Salome to kind of let us go through this process.
Yeah, thank you so much, Chanel. And so a lot of the glossary that you've received, a lot of these terms were developed using the CDC's Health Equity Style Guide. And so when you're reading it, just to give you kind of this is a snapshot of one of the pages, but to give you some guidance on how to use the glossary. So you'll see that the way we kind of put it is that we give you the term to avoid using, along with an explanation of why you should avoid using it and some suggestions. And so here on this, in this specific example, it speaks to terms that are really helpful in describing key populations, as well as principles. And so some of the terms here are to avoid using are vulnerable groups. When we're talking about people with chronic diseases or people who are experiencing a disease or illness, we want to speak to more so separating them from their illness. And so instead of using terms like diabetics or diabetes patients, we want to say people with diabetes, right? Or people who are diabetic. And so really making sure, and one of the things that I try to ask myself, even if sometimes I don't have the glossary to reference, is really thinking about, am I capturing a community or an individual's lived experience? Am I really, and Chanel spoke to this more, but thinking about the foundation of the word that you're using, or the term that you're using, and really making sure that you are really holistically in capturing an individual or a community's lived experience, and not necessarily removing them from the entire population or the entire community, but making them a part of the conversation. And so on the next slide, you'll see that from our environmental scan, these are some of the terms that kind of came up quite often. And so one of them was vulnerable populations. And this is a term even in public health and even just in learning in our academic world and learning about public health. This was a term that in my experience was always often used. And so I know that some of these terms are terms that we've experienced or we've learned from the public health lens are inclusive, but oftentimes they are not. And that is because they separate communities or individuals from the entire, it's kind of promoting an exclusivity public health lens versus an inclusive public health lens. And so instead of saying vulnerable, because vulnerable to what, or what is the reason for the vulnerability, we can use words like populations oppressed or under the threat by, and explaining further in detail what that is. Along with high risk individuals, like what Chanel was saying earlier, are not inherently at risk or high risk. And so speaking to the high maternal mortality rates among Black mothers, we can say populations disproportionately affected by, maybe it might be racism in this case, or other social determinants of health, however, not making them inherently at risk, or using that language that really promotes that they are inherently at risk. Underserved, under-resourced, underdeveloped, a lot of those kind of words with the root under, we've seen that this is not language that we should be including within our scope of work, because individuals are not responsible for their limited access to care, right? And this is the main point of the conversation we're having today, is to really understand how to better frame why that is and what that means. And so maybe we say people who are medically underserved. And so really making sure that as you read the glossary, you'll see that there are many examples, but really making sure that as you're even yourself filling out reports or any other documents or anything else that you might be giving to the public or to even partners, really asking yourself, have I encompassed or holistically really encompassed the community or whatever it might be in that situation. And so with the next slide, we're going to give you an example. And so I'm going to read this Title V example, but as I read it, I really want you all to throw into the chat some terms that really stick out to you. Either they might make you feel a little cringe, or they are just not really terms that are inclusive. And so as I read it, please feel free to throw into the chat what terms stuck out to you. But it says that despite program successes continue to be impacted by extreme amounts of violence in fiscal year 19, affecting participation levels. With Title V support, plans to expand their workforce development programs to target more vulnerable young fathers in an effort to reduce both recidivism and community violence. And so I'll give a couple seconds for folks to kind of just throw into the chat really quick. We have target vulnerable. Yeah, that definitely stuck out to me. Another word that stuck out to me here is violence. But we can go on to the next slide. Community violence, yep. And so what language sticks out to you? So extreme amounts of violence, right? vulnerable young fathers and community violence. And so just this kind of this language around violence really kind of, for me, is a little cringe because it doesn't really address why that is, right? What is the root cause of this violence, and how can we better support these young fathers, right, in communities? And so in our next slide, we'll show you an example of what it would look like to reframe this. And so it reads this: despite the successes, the program faces extensive challenges recruiting and keeping membership due to resource and capacity limitations to keep participants protected and safely engaged. Participants face discrimination within the workplace and limited economic opportunities that perpetuate dangerous conditions, resulting in preventable violent acts against them. We must implement our plans to expand workforce development programs to help young fathers within the community. And so as you can see in this reframing, we completely removed vulnerable, right, from young fathers, and promoted a sense of empowerment, right, of really addressing what it is, right, and that is capacity limitations, and making sure that we are keeping young fathers and communities protected and safely engaged. And then in the end, all encompassing that the need to expand workforce development to support young fathers. And so in this language, we can see that it really sounds like, you know, we are capturing a community, and we're trying to make sure that the community feels supported through the language that we are providing to the public. And so I'm gonna hand it back over to Chanel so she can explain some suggestions for reframing through the public health narrative.
Thank you so much for going through that activity and kind of going over the guidelines with the group, Salome. I'm really hopeful that that was helpful for our next part of our conversation today. But before we jump into practicing some of those things that we've learned, I also wanted to provide some suggestions in terms of how we reframe with this social justice-based public health narrative or a health equity lens perspective. And so as we are writing these narratives and writing these executive summaries in our Title V applications or state annual reports and applications, or any type of material for that matter, there are multiple things that we can consider. And one of them is the history and the role of public health. And so understanding that we, as an institution, we have not always protected and supported groups, specifically BIPOC communities. And so being transparent about that in the history and in our discussions, in our narratives is extremely important. Identifying what's at stake, actually name the threats and the source. So what do we actually mean by someone being at risk for a certain condition? Again, I would encourage you all to continue to read through these documents because there's a lot of nuance, and no term specifically is wrong or bad. It's that we're oftentimes being too vague and not attributing the source of the cause that's harming certain populations, or we're not even understanding or celebrating the strengths of a population. We're so sometimes so used to speaking in language that is disparities forward, that we're not thinking about the wonderful aspects of a community that is actually making their health outcomes better. And so things that we want to make sure we consider as we're reframing our narratives moving forward. One thing that we also want to encourage is that we're actually allowing residents tell their own stories. So obviously we encourage data-driven work, but we also want to make sure that the data is qualitative and that we're having individuals provide their feedback or provide their stories to make this rich reframe of our narratives. And ultimately, the purpose of harm reducing language is to challenge the dominant public health narratives and the conventional terms that we've seen and highlight those root causes. So yes, strength-based language, excuse me, that is what we're trying to move forward. And also, it's not necessarily written here again, but being accountable, making sure that as an agency or as any type of organization with power, that we are being respectful of that and understanding that there needs to be respect being shown both ways. And so accountability, I think, is really important, and transparency, again, as we're thinking about the histories of our interactions and our relationships. So I believe, I'm gonna double check to make sure we don't have another slide to go through, but we should be, yes. So I will take the time to open up the breakout rooms. This is just a slide where you all can review some of the resources. This is already a part of your in your state folders, but there's also a link to the CDC Health Communications Health Equity Lens. So they also have some guidance that also helped form that glossary of terms that Salome developed for Innovation Hub. So without further ado, I'm gonna open up all the rooms, and we should have about, oh, we're good on time, about 20 minutes. And there'll be 2 state teams in each group. So there'll be 3 breakout groups that will look at individual texts, and then we'll come back and just kind of discuss how that process went. So. Are you all able to, okay, I see. If you did not come up with a perfect reframed paragraph, that is completely okay. I think it's more about the conversation and understanding how that reframe process goes, so that we can, practice and make sure that we're doing better as we're moving forward. We only have about 5 minutes left. So I want to encourage one person from each group to provide like a quick round robin on how they felt that activity went. So I've been speaking a lot. So anyone from the Alaska, Pennsylvania group want to unmute and just share really quickly how they felt that went?
I'll share. So I'm Margaret from Alaska, and we had discussed a brief paragraph that we had written in what's called an epidemiology bulletin about a year ago, discussing the preterm birth rate and some disparities, particularly with an increasing rate among Alaska Native people. And I found it really helpful. There were lots of good suggestions. One of the things that was pointed out was some vague discussion in our original text about reasons for the disparity. We used a lot of couching terms like likely, do, may be, instead of really calling out what some of the things that we know are related to disparities, like discrimination, lack of access to healthcare. And anyway, I thought Lena as well had some great suggestions. I don't know if you want to share anything else there, but I found it really helpful.
Thank you. Lena, you feel free to unmute if you want. If you don't, I'll pass it on to the next group. You're good? Okay. Group 2, I believe, was Virginia and Louisiana. So anyone want to kind of give a highlight on how they felt that activity was or went?
I'll share. I based off of kind of everyone's feedback, I think that it really allowed us to kind of see how another layer of our reframing was the use of gendered language in our example, and as well as Stephanie pointed out, positive reframing or using like positive language. And so instead of speaking to kind of the limitations or the lack of access that the community in our example, which was women and girls, were experiencing, kind of having more of a positive framework and addressing, solutions that can better support some of the experiences that were pointed out. And so I think that was another layer that all of us really seemed to get some really great feedback and learn more about.
Awesome, thanks for sharing. And then anyone from the last group want to share high level feelings about how the activity went or any lessons learned?
I'll share. I do believe that after this, well, let me say this approach has really opened our eyes. We find it to be definitely needed, although these are terms oftentimes that we write in, not to say that we necessarily agreed in it, but we never really had the tools or let's say even resources to share our message in a way that is less harmful. So I think this is very thought-provoking for us, and it's going to challenge us in ways that we didn't even know we had the power to do before. So I find this to be very powerful when we're looking at really putting our actions behind our words. So I in Wisconsin am so grateful, and it was so crazy that it came at the right time, because I was asking, how do we determine, when we are changing language and we're reviewing applications, what determines, how intense or how provoking can we be, and what determines that? How do we know if it's appropriate or not? And so I think this came right at the right time for us, and it's to make us a bit more conscious of how words impact the change in our work.
Thank you so much for sharing. I think one thing that I want to emphasize is that, we're learning too. AmChip is taking the guidance that you all have in your folders, and we're adapting it. And it's hard, like Salome said, these are terms that we've been using in our professional lives, academically. These are things that we have to unlearn and really be thoughtful and conscientious about moving forward. So I want to applaud you all for taking it in so enthusiastically, and I'm glad that you all, encouraged us to have this conversation. This is really as a result from feedback from you all. So I say all that to say thank you so much for your continued participation. And if there are certain other things that you all want to learn or discuss, this is what this group is for. So please don't hesitate to reach out to us. I know we are right at 4 o'clock. I'm not going to go over. So I want to thank you all. We will send a follow-up email for whatever we didn't cover. So thank you guys, and have a great rest of your week.
Take
Thank you
care. Bye.
all.
Thank you.
Bye-bye.
Thank you.
Chanel, that was awesome.
I'm glad it went well.